UK Embassy. Okay, let's start with uh, the the content of the meeting. Dr. Pak Indra, tolong daftar acara.
So this is, I'm sorry, this is Indonesian language. This is knowledge sharing KARS. KARS is Indonesian Committee on Accreditation to Hospitals. It's the 54th time. The topic is delivering world-class care at Oxford University Hospital NHS Foundation Trust. At Friday, 26 January 2024 at 19:30 to 21:30 Indonesian time. We will start this. I'm starting the meeting. I'm Dr. Hani Ronosulistyo. I'm obstetrician, Fisqua. And next is we are, as usual, we are going to pray to start with and close everything with prayers. But I'm sorry, we are going to pray in Bahasa Indonesian because Dr. Johnny is not well. After that, it's the speech from our executive chairman, Dr. Sutoto, who's still in Mecca doing Umrah, and it will be done by our honorable executive secretary, Dr. Jyoti Atmojo, pediatrician Fisqua. After that, we have a speech opening words from Dr. Bala Sritkar from NHS London, and maybe Cynthia is going to accompany him from the UK Embassy Indonesia. After that, 9:45 for 1 hour, the main topic, delivering world-class care at Oxford University Hospital NHS Foundation Trust by 4 persons. Yeah, so it's wait a minute, Dr. Mrs. Katrina Kensington, Dr. Shu Pafford, Dr. Muhammad Salem, and one more is Dr. Alex Ramsden. So there are 4 speakers, and then there's question and answer after that for about 30 minutes, and the closing will be by our secretary executive, Dr. Jyoti Atmojo, pediatrician Fisqua, and closing prayer from me again. Okay, we will start with the prayers. Bismillahirrahmanirrahim. Yang terhormat Bapak Ibu-Ibu pembicara dari Inggris, Miss Catherine Kensington, Dr. Bala Sritkar from NIS, and friends, also to our surveyors and honorable colleagues from the hospitals from whole Indonesia who's gathering here. Kita seperti biasa akan menundukkan kepala kita sejenak untuk menghadap kepada Allah Subhanahu wa Ta'ala untuk meminta perkenannya, meminta perlindungannya agar acara ini bisa berjalan dengan lancar, tanpa gangguan sinyal, tanpa gangguan yang lain, dan semoga semua pembicara dalam keadaan sehat, dan kita juga meminta supaya kita diberikan kemampuan untuk bisa menangkap sebanyak mungkin dari yang dibicarakan. Doa ini saya bawakan dalam agama Islam, mohon yang bukan beragama Islam dapat menyesuaikan. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin, hamdan naimin, hamdan syakirin, hamdan yuafi ni'amahu wa kafi mazid. Ya Rabbana lakal hamdu wa lakal syukru kama yang balili jalali wajikal karimi wa astimi sultanik. Ya Allah, ya Rabbana, hanya kepadamu lah kami bersujud dan hanya kepadamu lah kami memohon. Iyyaka na'budu wa iyyaka nasta'in, ya Allah. Pada hari ini kami berkumpul seluruh Indonesia untuk menambah ilmu thalabul ilmi seperti yang Engkau perintahkan kepada kami, ya Allah. Berikanlah kami selalu berkat-Mu, berikanlah kepada KARS selalu bimbingan-Mu. Semoga KARS bisa membawa teman-teman dari rumah sakit untuk bisa masuk ke jenjang internasional dengan menampilkan banyak rumah sakit terkemuka, ya Allah, seperti dari Oxford, dari UCLA, dan beberapa rumah sakit yang lain yang telah kami uh, ajak untuk berbicara dalam acara ini, ya Allah. Berikanlah kami selalu kesehatan dan berikanlah selalu kebahagiaan, ya Allah. Jagalah keselamatan, kedamaian di dalam menjelang pilkada yang akan berlangsung dalam waktu dekat, ya Allah. Semoga Indonesia tetap aman, tentram, dan berjaya. Ya Allah, berikanlah kami selalu perlindungan dan rahmat-Mu. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahirabbil alamin. Amin. Selanjutnya kami persilahkan Sekretaris Eksekutif Bapak Joti Atmojo untuk menyampaikan prakata mewakili Ketua Eksekutif.
Terima kasih, Dr. Hani. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good evening for all our speakers. Di malam ini kita berkumpul kembali dengan mendapat kehormatan kehadiran dari para pembicara dari Oxford University Hospital yang akan berbagi ya bagaimana menunjukkan arah gitu ya supaya rumah sakit di Indonesia juga bisa mencapai tataran internasional. Jadi mudah-mudahan apa yang beliau sampaikan akan sangat bermanfaat untuk kita semua sebagai praktisi di rumah sakit. To the distinguished speakers from Oxford University Hospital, we, all of the KARS family, express our heartfelt gratitude for your willingness to participate as speakers at the KARS knowledge sharing event. The KSK serves as an essential communication media between KARS and all hospitals in Indonesia, aiming to share knowledge to enhance the quality and safety of hospital services. Semoga acara ini akan berjalan dengan lancar atas pertolongan Allah Subhanahu wa taala, dan dengan mengucap bismillahirrahmanirrahim, acara knowledge sharing KARS yang ke-54 ini kita mulai. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Jyoti, for your kind speech. Now, I will ask Mr. Balastrikar from UK to speak as the officer from our UK Embassy in Jakarta.
Thank you. Good afternoon to everybody from UK, and good evening to everybody in Jakarta. Thank you for having us. I'm just going to say a few quick words about who we are and what we do. And if you're interested, I can tell you a little bit more about the NHS. I'm just going to share my screen and then talk you through that. Just let me know when you can see my screen. Just a very quick word.
Yes, okay.
Okay, you can see it?
Yes.
Okay, thank you. We are from Healthcare UK. We are based within DBT. We are funded by Department of Health and Social Care, our regulatory body, and also by NHS England, our commissioning group, who are providing service for the local population. Our ethos is largely to provide support to the UK organizations, healthcare organizations, to ensure partnership development within international health communities. And largely that's one of the reasons why we are here, is to support our NHS organization, Oxford University Trust, to give you the context as to what we do and why we do. The NHS is a large body of organizations, a eco family, and so that we support most of them effectively. I think for us, the most important thing is to share and learn our experience and expertise with the health economies, but also to help and learn in a reciprocal way from other health economies. So very quickly, what we do is we collaborate with other parties, largely in research and learning, to share and experience our opportunities. We also have a lot of experience within the NHS community that we would like to share with other partners. So I think that's a very quick summary of who we are, what we do. Thank you.
Thank you very much, Dr. Bala Sritkar. If you don't mind, you can send your presentation to maybe at the chat.
Definitely.
So the people who cannot make it in a very quick time to read your English presentation. Thank you, Mo. Hopefully, our listeners, there are many who are interested in doing work together with England. And after this, thank you for Dr. Bala Sritkar. And is Cynthia here? Maybe you can have your chair for a few minutes.
To every distinguished speakers and everyone who come here, we really appreciate your time to join us to listen how Oxford University Hospital can deliver the international standardized to patients in the UK and worldwide. We are here thanks to Dr. Hani for the chance, and we believe that the UK and Indonesia have more another how we can collaborate and develop to support Indonesia ambition to be the next healthcare tourism, and we are keen to support your innovations in Indonesia. Nice to meet you. Please, you have your time to listen to our speakers sharing. Thank you.
Okay, thank you, Cynthia, for your help. We can do this meeting. Please, now we will start with the first speaker. Can you put the curriculum vitae?
Yeah.
Please, curriculum vitae. Indra, CV-nya.
So let's start. Oh.
I think so, yeah.
Cool. Thank you so much.
You don't have from Dr. Alex, yeah?
Maybe
it's not time to
he was a late edition.
Yeah, okay. Yeah, it's the new system. Okay, please, Catherine, have your place.
I will share my screen. Oh. Can you see that okay?
Yes, okay, good.
Great. So thank you ever so much for inviting us, Dr. Hani. It was lovely to meet you when I went to Indonesia in the beginning of December. It was an amazing trip with Healthcare UK and Cynthia, and it was really lovely to get to know your health systems and some of the people that I met. So thank you, and it's a real honour to be here talking to you today. So we're gonna start with talking about delivering world-class healthcare as we do at Oxford University Hospitals, and I've got some clinical colleagues that are with me. Just a little bit about my background. I've been working, I'm a nurse by background, a cardiac nurse, and I've worked at Oxford, and then I've done multiple jobs around different organisations and hospitals, but always in the NHS and always in the UK. And I've been working at Oxford this time for a couple of years, and recently focusing on our international strategy, hence why I had my trip in November. So some of the slides and some of the things that I'm talking about today was learning from meeting you all out in Indonesia.
Thank you.
So this is a little bit of background just on us, the four presenters today. And they will introduce themselves. So we're going to do it in little sections. So I'm just going to do the overview, and then my colleagues will do their bit from their perspective from a clinical one.
Okay.
So while we are here, as I say, we had a recent visit. I met lots of people, and if you look at that picture in the background of that slide, taken by Cynthia actually, you saw how
The
dynamic.
slide is not on.
Oh, the
The
slide
slide
not
is
on.
not yet. Not yet.
Oh.
You share screens, not yet share screen.
Hold on,
It's
sorry.
not yet.
Hold on, bear with me. I've lost it a bit actually.
You've got your bottom of your thing, share screen, and then
The
if you can click on
green
it.
one. Below the green one.
Yeah.
I've lost Zoom actually at the moment. Hold on. Hold on a sec, sorry.
Can you see yourself on your screen?
No.
Right. Have you got an extended screen?
Yes.
Okay.
So probably, oh my goodness me, sorry.
That's okay. Just do Alt and
along the bottom bar, Catherine. Have you got a full page of Zoom?
I haven't got anything. I did have something on my bottom bar, but I haven't got anything at the moment. I don't know what.
Right.
Happened.
Just
You want
Control
me to
Alt
dip
and
in
Tab.
and do my bit while you're
Yes,
sorting
do.
out?
Yes,
Okay.
sure.
Okay, let me see if it works for me. I'm going to share now. So let's see how we get on with this.
So Catherine, you can just do Alt and Tab and you'll find all your screens.
Yes, sure.
Can
It's
you
okay.
see everybody that it says hematology?
Yes,
yep.
yes.
There, you've got that?
Can you see it, Catherine?
Yes.
Can you see hematology? Yeah.
Yeah, we can, yeah.
Okay, so we three clinicians, I mean, there's lots of clinicians who would love to present today. So we've just taken three kind of examples of our services. So I'm a consultant hematologist here. I'm Sue Pavard, and I'm president-elect of the British Society for Hematology. And just to show you the specialist hematology services we have in Oxford, we have on this right-hand side, I've put all the malignant hematology services, and they're actually quite big, all of those: myeloma services, lymphoma, cellular therapies, and we've just established CAR-T, bone marrow transplant, molecular hematology. And down this left-hand side, I've put the non-malignant hematology, which is my areas, really. So they're the ones I'm going to talk about. We realise we can't cover everything. We will be brief, don't worry. But just to say also that this is underpinned by all of the hematology laboratories. We have an SIH MDS service, so it's full bone marrow integrated reporting services for diagnostics. And I'm director of the Oxford hematology laboratories. Moving on, our immunohematology services are award-winning, and we really run services for the whole of the region and some of the whole of the Thames Valley area. These are the diseases that we cover, and we also run up-to-date clinical trials for our patients who are particularly tricky and for patients across the region, so that we are able to offer sort of progressive and up-to-date therapies for patients, either with very refractory disease or those where they're quite early on in their disease, but they are trialing new drugs. The part of transfusion services is actually patient blood management. So it is the care of people who would be at risk of having a blood transfusion. We're very mindful to try and use transfusion appropriately to avoid excessive risk to the patient. And I'm sure you've heard of the buzz term patient blood management. And part of that is iron deficiency, identification, and management. So after a sort of 3-year business case, we started practicing an outreach iron deficiency management service in a community hospital. So these people can avoid the acute care hospitals. We started on the 1st of October 2019, and we were lucky in that we managed to continue through the pandemic because patients did not need to come up to acute hospital where they would be unsafe during the pandemic. And secondly, we were able to keep people very separate. And we thought it was really important to manage iron deficiency through this time because it increases the risk of infections. And so it's important that people are fit for the pandemic, as fit as they can be. So when we first started in October 2019, you can see how quickly our referrals grew and where they came from. This is our 2023 data. We're now seeing 100 to 150 patients per month, and there were 1,400 consults last year. We've continue with our metrics to see where are these patients coming from, and most are now from primary care, which is what we wanted, because this is the undiagnosed heart sink patients for GPs who are really suffering with their iron deficiency, but it's not being recognised. So through this, we've raised awareness. We also see a lot of perioperative patients because of the NICE guidelines on the management of pre-op anemia and how that improves post-surgical outcomes. And the others are from secondary care. We also offer private iron services at Oxford, the Oxford Iron Clinic, and we run this from the main site, the John Radcliffe Hospital, and this is a busy practice. We do online consults for overseas patients, and some want supervised, if you like, remotely, and with collaboration with the local care teams. Obstetric haematology has been a really expanded subdiscipline of haematology over the last 20 years. And we run an international educational course every September, which takes place in one of the Oxford colleges, St Edmund Hall. We cover all these subjects. It's 3 days, residential, and it's even with those 3 days, it's very difficult to cover everything. But by and large, international students and consultants from obstetrics and from haematology, they come and they really enjoy it, and that leads to long-term collaborations. So we haven't yet had anyone from Indonesia, but we've certainly had people from Malaysia, from the Philippines, and other all over the world. So we'd very much welcome you on that course. We also set up training programs for overseas doctors, and this is one we do with Sri Lanka with transfusion services. So these doctors who come over, they come for a year, and it is their penultimate training year before they are consultants in Sri Lanka. And this is absolutely mutually beneficial. These doctors are fantastic, and they really engage, they learn, they share ways of doing things in Sri Lanka that we benefit from, and vice versa. They take home UK practices. We send them on transfusion courses with the NHS Blood and Transplant, and they participate in our weekly incident reporting meetings, safety meetings, and see transfusion practices from the donor side as well as the recipient side, and participate in immunohematology clinics and bone marrow transplant clinics. This really just shows the figures of our blood transfusion laboratory. So our laboratory manager is also the lead for all blood bank managers in the UK, and they are incredibly busy. You can see the volumes of group and saves and blood issue that they're undertaking. I just want to do, in my final slide, really just to show Oxford's participation in the pandemic, because I think this was absolutely world class. So first of all, the Oxford vaccinology teams worked with AstraZeneca, the company, and we were the first country to sort of roll out the vaccine in a structured programme, which started on the 4th of January 2021. In 2020, we had vaccinated healthcare workers and we'd run the vaccine trials. I don't take any credit for this bit, but that was absolutely fantastic, and that vaccine saved hundreds and thousands of lives. At the time of the first vaccine, already 100,000 people had died from COVID. What we then saw was a horrible, rare reaction to this vaccine when young people who'd been previously fit and well came with thrombus in their cerebral veins, with secondary hemorrhage, coning, and a very high fatality rate of 75%. So I was alerted to this, and I set up a panel of 6 haematologists, and we ran across the UK daily multidisciplinary team clinical meetings so that we could support haematologists and other physicians that were seeing these cases, and they had absolutely up-to-date treatment advice, and we all worked at that together so that no one haematologist felt alone in managing this terrible condition, certainly the worst condition I've ever seen. It was a new syndrome. We helped define it. We've continued international collaboration, and we now know that this condition isn't only after vaccines. It's been seen after adenovirus infection itself and spontaneously. So this isn't going away, but you can see when the vaccine, our politicians listened to us from Oxford and they withdrew the AstraZeneca vaccine from the UK, and you can see how our cases escalated through January, February, March, April, and then died away as the vaccine was removed. So that's an example that I'm really kind of proud to share of how in Oxford we kind of led the way nationally and internationally on that life-saving through the pandemic. So that's a real sweep through of haematology, and I'm really glad to have had the opportunity to share that. So I do thank you very much for your attention.
Thank you, Sue.
Thank you.
Maybe
Thank you,
after this, many Indonesian doctors will come.
Thank you.
Hopefully. Okay. Catherine, who's next?
Can you see my screen now?
Yes. Okay, now.
Excellent. Excellent. So thank you, Sue, for stepping in. So yes, we've covered that, and this was a slide I wanted to show you about why we were here, and the picture behind that is a picture from the room when I met everyone, which was incredible and taken by Cynthia. So I was really interested to hear about the health strategy that you're developing, and I did feel that after meeting a lot of people and talking to a lot of people, that our values are quite aligned in what we're all striving to achieve, and which is why we're here sharing our expertise. So just a bit about us then. So we're one of the largest teaching hospitals in the UK, with multiple subspecialisms as well as an international reputation, as Sue has already said. We've got 1,200 beds with 14,000 staff, and there's 4 hospital sites and 1 million patient contacts per year. Oxford University are a different organisation, so we don't represent them, but we have a very close strategic partnership with them. As Sue's alluded to, we've got a huge research portfolio, We run about 1,500 trials per year. And we also very involved in innovations and developments. We've got a lot of world-renowned professors and clinicians that do an awful lot of work and innovations. There you go. And so talking about values, and this was a real interest to me when I met everyone. Our core values are sort of listed in our strategy as learning, respect, delivery, excellence, compassion, and improvement. And these sort of underpin all of the things that we do, and all the things that Sue has talked about already and that you'll hear a bit more about later. I won't go through all the detail because you can imagine behind this is a large strategy, but it's really important to us that we work with people that have similar values and share common ground. And this is a busy slide, and whilst I make no apologies for that, it shows that in this area down here, that the values are core to our whole strategy about how we move forward. And that sort of world-class impact and that ability to work internationally is part of that strategy. And then the principles of our clinical strategy are that we work on all these listed things because we wanted to turn in what was the theory into how we're actually going to do it. And so there was conversations with all the clinical divisions defining what we wanted to do and how we wanted to do it. And both parts of our clinical strategy involve making sure that what we do locally is really important with our system partners, but also moving on to develop specific specialties that both nationally and internationally we can collaborate on. These are a list of our services where we know that there is particular expertise, but that's not isolated. Things change and grow all the time when this strategy was written. And then another example, and Sue mentioned it with the pandemic, is that we, in this presentation, which obviously we'll send to you, is a link to a book that we created, that we created as a result of all the learning from the pandemic. And it talks about the values and underpinning it and how we did it. And it's got pictures and it brings to life the values of how we responded to that, which will tell you quite a lot about our organisation. And then this is just a few examples from our website of recent articles around innovation. So for example, our stroke unit is now providing life-changing mechanical thrombectomy treatment 24/7. And this helps people recover from strokes, hopefully reducing disability and preventing long-term care needs following that. We've got a discharge to assess initiative. There is also an mRNA cancer vaccine, and the first patient's been treated this month, and this is particularly focused on head and neck cancer. There's a link here to our website where all the sort of updates and the news happen, but this is kind of an example of how we're constantly improving. And then talking of innovation, so we also have other innovations that we've actually talked to one of your hospital groups around. The strategic data environment, and this uses data for research, and there is you can use it for algorithms or you can use it for research. And at the moment there is 1 million pieces of data in this database that is useful to other people to access on a very secure way, and it helps develop services and provide that research. What we were saying to the hospital group is that more data in there, the better quality of information that we get out. And because your population is so diverse, and it could really add value in collaborating on things like that. We've also got an innovation hub that we set up within Oxford hospitals and the university, improving digital innovation adoption to help efficiency and effectiveness. And then we have other bits of software that we can share that help diagnose and treat strokes, that identify biomarkers for early detection of cancers, and then software to support the automatic and immediate analysis of a stress echo. So these are just small examples of there are things that we can do to support each other. And then in terms of our international strategy, it's something from my visit when I went there, You can see the square in the background, that was from my visit, when we were talking about what we can do internationally and how we can share and how that will benefit us both. And things like the clinical services, second opinions, medical placements, Sue's already mentioned, educational programs, joint research, as well as sort of skills training and innovation sharing is all things that we're really interested in sharing. And that was a picture, that's my contact details, our YouTube channel and our social media links. This was a picture of me with somebody from the square when I went into Indonesia, and she was a student wanting to learn English, and she was absolutely lovely. So I'm now going to hand over to Mo, who is our clinical lead for cardiothoracic anaesthesia and critical care.
Thanks, Catherine. Can you hear me okay?
Yes, okay, good, very good, Salam.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Hope everyone is having a
Walaikum
nice
salam. Yes, thank you.
I want to talk about Oxford and the Heart Centre in particular. As Catherine has highlighted, I'm lucky to be the clinical lead for the cardiothoracic anaesthesia and critical care. And on the left-hand side here, you can see how big the team and how diverse it is. And this is just the part of the team that will be looking after a single patient having an open heart procedure in Oxford. And of course, there are many, many more people in the background. So we contact Sue when we have abnormal bleeding and she helps us out. But this is a talk for another day. I think you will have to go to the next slide for me, Catherine, sorry. So our intensive care unit is platinum rated, and I think this is our own intrinsic in Oxford rating for quality assurance, and platinum is the highest that you can achieve. It's a medium-sized unit where we have about 14 intensive care beds. But where there's a business case to increase that to about 21 beds. There is a 5 days a week pre-assessment clinic that's covered by consultant anaesthetist to see patients, consultant ward rounds on daily basis, and we have an excellent day of surgery admission for elective cases, and we run an enhanced recovery after surgery program. There is weekly subspecialty input from a multidisciplinary team to help improve patients' outcome, and we have a monthly morbidity and mortality meeting. Catherine, can you go to the next slide, please?
Yeah.
And I think I got this data from the GIRFT, which is the Get It Right First Time from the Department of Health in the UK, and it highlights how busy the unit is compared to the national average. So our occupancy rate is about 111%. And our combined sort of level of care runs at a level 3 on a 95%, where the national average is about 80%. So the unit is busier than other places in the UK, which means that we actually have a more diverse skill to deal with sort of sicker patients or more complex cases. And can you go to the next slide, please, Catherine?
Sure. Yeah.
From a thoracic surgical perspective, there is great contact between the anaesthetists and the surgeons to run patients from a pre-op perspective. We have an excellent day of surgery rate admissions. So we run an 85% compared to 54% nationally. Thoracic patients luckily go to the ward, which is a higher average than nationally. So nationally, it's about 60%. Critical care admissions is a lot lower afterwards, and we have a higher rate of minimally accessed surgery compared to other centers in the UK. And could you go to the next slide, please? And when we look at cardiac surgery, so I am very proud to highlight the fact that we have the lowest deep sternal wound infection rates in England. So it's less than 0.05% versus over 0.5% nationally. Our mitral valve repair rates for degenerative valve disease are higher than the national rates. and we have an excellent median length of stay. So patients stay lower than they in intensive care and or in hospital when they are compared to other centers. In terms of how long do the patients have to wait till their surgery is offered, you can see the gray line in the middle is the NHS standards, and nationally sort of lots of trusts are not achieving that, and we are actually able to offer most of our patients surgery as soon as possible within less than 18 weeks of referral, which means that we can treat patients as soon as they present and not needing to deal with sequelae of the disease and complications. Next slide, please, Catherine. And when we look at our return to theatre days after procedures, so we have a lot lower rate compared to the national average. So our patients luckily don't have to go back to theatres. As I've mentioned, the deep sternal wound infection rates is the best in the country, and so we have better outcomes when it comes to strokes after having cardiac surgery, and we also require less dialysis after surgery. So our outcomes overall are better than the national average, which means that we're doing a much better job, I'm pleased to say. And next slide, please. So we also have a cath lab, which is run by world-renowned cardiologists who are excellent colleagues of us. 6 cath labs. There's an excellent coronary intervention service that's run 24/7. We have a great structural heart disease program, which deals with transcatheter aortic valve implantations and mitral valve edge-to-edge repairs. And they are able to achieve great results. And I think our average is that we do about 6 TAVI cases a day, and the national average is less than 4. So we actually do very well with that. We have an electrophysiology service where we do lots of heart devices and cardiac ablations for patients who have rate and rhythm disorders. And I think it's a great collaboration between my department, the anesthetic and intensive care department, and my colleagues in the heart center that allow us to deliver this excellent care. Thank you very much.
Okay. Next, Dr. Alex.
Hi, can you hear me?
Yes, thank you.
Fantastic. Hi, so my name's Alex Rams. I'm a consultant plastic surgeon, and I work in one of the hospitals in Oxford, which is all part of the same trust, which is the Nuffield Orthopaedic Centre. And that is a specialist orthopaedic centre, of which there's only 6 in the UK. So it's a big orthopaedics service that specialises in complex reconstruction, in sarcoma, and also in bone infection. So it's actually a national stroke international leading centre in bone infection. Next slide, Catherine. So in the unit, there's over 150 beds, there's almost 50 surgeons, there's 8 theatres that is only doing orthopaedically related surgery. So it's a very, very niche specialist centre, really concentrating on complexity. And so we take a referral base both locally, but also nationally and internationally we get referrals. Next slide, please. An example of a patient who would be our sort of average patient is someone who's a smoker, they've got comorbidities, they have a motorcycle accident abroad, they have multiple injuries such as rib fractures, pneumothorax, ITU admission, and they get an orthopedic fracture, which is difficult to treat and gets infected. And it doesn't just get infected with standard bugs, it gets infected with multiply resistant bugs. There is soft tissue defects. So actually, this patient is suddenly complex. They need lots of different styles and types of treatment. And so the bone infection unit is a good way of treating patients like this and putting it all into sort of one effort to get the patient well quickly. Next slide, please. So what we do is we manage complexity, and the way that we do that is we front load when we see the patient that all the specialties that we need to see that patient, we'll see them in a combined multidisciplinary clinic. And I think this is one of the key things about Oxford, is that it's got all the different specialties in one city, and a lot of these specialties have got internationally renowned figures in who can see patients and can lead and can manage really complex patients. So this patient will be seen at the same time by an orthopedic surgeon, a plastic surgeon, and an ID physician, and specialist nurses, all in the same clinic on the same day at the same time. And that allows us to make decisions without delay and communicate that clearly to the patient as to what the plan for that patient is going to be. The patient then goes home and then is admitted for one elective procedure. So we feel very strongly about single stage surgery because that is efficient for the patient, it's efficient for us, and it delivers timely and effective and cost-effective care. And so, for example, this gentleman would have sampling to find out what bacteria in there and what their sensitivities are. And that's why the ID physician is very important. They would have their metalwork removed, they would have their fracture addressed, they would have the infected bone removed, and then they would have a reconstruction, in this case with a frame on the outside of their leg, and a plastic surgeon would move skin or muscle around to get the skin healed. Now, in a lot of centers, to get all of those three specialties in the same place at the same time is extremely difficult to do. But if you get them all there, then that patient has one operation, they have an inpatient stay of 12 days only, they're discharged on the appropriate oral antibiotics, they have a frame removed quite quickly, and that gives you a very high chance of getting rid of the infection. So we would expect greater than 95% chance of getting rid of the infection in a case like this. And by international standards, that's extremely high. And osteomyelitis is sometimes described as a disease that there's no treatment for, but that's incorrect. There are treatments for it. And this chap was back at work at 6 months, working as a stonemason, which is making and shaping stones for buildings, which is very high demand, using his leg again. So he quickly got back to work and got back to full function. So by front loading people's treatment aggressively and early, it means that these patients can get on with their lives and they're not delayed for long periods of time. Next slide, please. So as an example of one of the things that the Nuffield Orthopaedics Centre does, the treatment of fracture-related infection, chronic osteomyelitis, or prosthetic joint infection, so that's infected hip replacements, knee replacements, for example, we are an international leading centre and get referrals. And part of that, we then make sure that we're safe. So we regularly audit and publish our results. We host international fellows from all over the world who come and stay for a period from a week to a year to come and work with us. We organise an annual bone infection conference, which again is an international conference where people come from all over the world for a 2-day conference on bone infection. And really what we are very keen on doing is managing that complexity that other hospitals might struggle with. And we do that through multidisciplinary team working. And I think that's just a part of the orthopedic setup in managing complexity, but it also represents really one of the things that Oxford is particularly good at is that multidisciplinary care, because we've got all of the specialties in a pretty small space. Thank you very much. That's me, Catherine.
And that's what.
Thank you, Catherine.
We're all worried about running out of time.
You speak too quick. I don't know whether everybody understand or not. Maybe Catherine, for the next time, we can. This is a preliminary presentation from Oxford. Maybe we can make every month only one speaker who can talk more deep and more slow and something like that, one by one, and maybe people are interested to ask. especially when the slides come first, so they can read from the slides first. So
Yeah.
it will be more useful. Yeah.
Sure.
Okay. So dear friends, dear colleagues in Indonesia, we have 1, 2, 3, 4, 5, 6 speakers already. The first is Dr. From NIH, Dr. I'm sorry, what's his name? Cynthia. Where is Cynthia? Okay, it's the first one is Dr. Bala Sritkar from NIH is talking about the organization, and then Cynthia from the UK Embassy, and Catherine from the boss of the boss of Oxford, and Dr. Sue Pafford from hematology, Dr. Mohammed Salem from anesthesiology and cardiothoracic operations, and Dr. Alex is in orthopedics and plastic surgery. So we are open for any questions. Please, you can raise your hand and ask in Indonesian, and Miss Cynthia will translate your questions. Okay, please raise your hand, and Cynthia will.
Pardon, Dr. Hani, there's someone. Yeah. Sorry, Dr. Hani, there is one question from Rahayu Budi Mujianto to Dr. Muhammad Saleh. Maybe I would like to read first. Thank you for Rahayu Budi Mujianto. Dr. Muhammad Saleh, there is a question. What electrophysiology services are performed in the cardiology cath lab in Oxford University Hospital? Thank you. Hello.
Dr.
Can you
Saleh?
hear me?
Yeah. Okay. Yes.
Okay. So the basic electrophysiology are the services that are delivered. There is pacemakers. There's cardiac resynchronization therapy device services, and there is secondary prevention in terms of implantable cardiac defibrillators. There is also ablation, which is related to AF mainly, which is the AF ablations, whether that is cryoablation or sort of electrical ablation. There are other issues that are related to this, such as delivery of various devices, such as left atrial appendage occlusion devices, which help reduce the incidence of stroke in patients who have AF. These are the main sort of electrophysiological procedures that we do.
Dr. Rahayu, maybe can you raise your hand so we can know to put you in? You can ask in Indonesian. Dr. Rahayu, bisa Pak Indra, tolong Dr. Rahayu di ini.
Ya. Terima
Silakan,
kasih.
Dok.
Ya. Terima kasih Dr. Muhammad Salim. Ya. Atas penjelasannya.
Ada pertanyaan lanjutan, Pak? Silakan.
Tidak ada, sudah cukup.
Oh, sudah cukup. Okay. We go. Thank you, Dr. Muhammad Salim. No more questions. So now we are going to Akyung Gatot Suharto. Bisa tolong dimasukkan? Silakan dibacakan pertanyaannya, Bu Cynthia. Pak Akyung bisa masuk?
Questions to Dr. Muhammad Salim. Please explain what the team did to lower deep wound sternal infection rate in England around 0.05% versus 0.62%. Thank you. That's the question, Doctor.
Okay. So there is a bundle that we apply in Oxford, and part of the bundle is related to antibiotics, the prophylactic antibiotic that is being prescribed to patients. The second aspect is related to harvesting of the internal mammaries. And I think part of that, so if patients are diabetic and they need bilateral internal mammaries, we usually tend to only use one of them because that tends to reduce wound healing. So we only use one at most patients if they're diabetic. And then there's adequate hemostasis. I think that plays a role. I'm not sure if Alex wants to come in this because sometimes we get them in for the deep sternal wound infections and they can fix that. I don't know, Alex, if you want to come in and maybe comment on that.
Yes,
Yeah,
please.
so plastic surgeons often get involved in cases with infection in the sternum or wounds that don't heal. But actually, in Oxford, we don't do very many because they have a very low infection rate, which is good. Reducing surgical infection is a major topic in itself, and there's not one magic thing that works. It's a constellation or a group of different things that we do simultaneously with each patient, and those will be audited, and we'll have standards about prep, about antibiotics, about careful surgical management of each patient. And the trust is very keen on applying those standards and maintaining them so that we can produce low infection rates, not just in cardiothoracic, but in orthopedic surgery or in general surgery, for example. So I think Mo's right. We would call it a bundle. I don't know if you quite understand that word, but it's a group of lots of different things that you do and you regularly perform them that helps to drive down infection rates.
Thank you very much, Alex.
Thank you.
Akyong,
Salam. Wassalamualaikum warahmatullahi wabarakatuh.
can we see your face? Put the camera down, Dr. Akyong. Oh, yeah, he's the senior. He's our senior, and he's very, very active. Thank you very much, Dr. Akyong. Maybe somebody else raise your hand. Langsung aja dalam bahasa Indonesia, nanti ditranslate oleh Cynthia. Silakan.
Yeah, it's Dr. Hani. There's a question from Dr. Eka Fiora.
Oh,
How does
okay.
Oxford University...
Dr. Eka, tolong masukin fotonya, orangnya.
Yeah.
Ya, please.
Oh.
Bu Eka masih mute. Welcome.
Okay,
Oxford University. All right. So the question is, how does it hide the part? Maybe Dr. Eka can
Coba Dr. Eka, suaranya
directly.
putus-putus.
Is it all right, Dr. Eka?
Yes, thank you. My question, how does Oxford University Hospital ensure the consistency of its high quality services standard across all departments? Thank you.
Thank you, Dr. Eka. To whom? To Catherine, maybe you can answer, or Sue?
I can certainly start the answer. It's an excellent question because we all, within our own services, we are absolutely mindful of quality and making sure that we are achieving that. But how does Oxford University Hospital have an oversight of that? There are certain things that we do. For instance, there is a very strong incident reporting system with a very low threshold for reporting incidents on a no blame situation, so that every time there is an error or a near miss, that is thoroughly investigated, and we make sure that we take the opportunity to learn from that. Secondly, there are regular safety messages that go across the trust. For instance, about safe management of anticoagulants or safe blood transfusion practice. So I'm sure the others can think of other examples, but all these are important. And we do have external peer review. So I mentioned our laboratories, for example. We have accreditation systems that we must comply with. And each time they happen, we get better and better. And in fact, we are inspected every single year. It's a hugely laborious process. But in fact, last year, they had absolutely no comments for corrections that were required. So we were very proud of that. And there's a lot of external peer reviews for different specialties within the UK. And we participate in those to accredit and audit other centres as well.
Yes, thank you. Maybe anybody wants to?
May I come in?
Yes.
I think as Sue has highlighted, it's related to multiple things, but I think one thing that is quite important, I feel, in Oxford is related to the culture. And in our culture in Oxford, we realize that the quest for excellence is a never-ending process. So it's not something that we'll say, yes, we are excellent and that's it, we're going to go home now. We need to continue to evolve because healthcare is an ever-changing dynamic. It changes every day. And as Sue has highlighted, incidence reporting is quite important, but it's not just that. We look at also the quality of incidence reporting and how we can learn from it, the culture and the safety culture within the hospital, and how we can be proactive, not rather than being reactive towards whatever is coming around the corner. And it is, I think, the best aspect about, what we do well is we listen to each other. So we highlight what we fear is a concern for any patient, and we listen. And I think the one thing that I think ultimately we share is that we are employed by the Oxford University hospitals, but we're there to serve the patients. And that's, I think, pinpoints why or how we look at sort of quality care in Oxford.
Thank you very much. Maybe, is there any questions, Cynthia? Not yet. Maybe somebody can tell us about patients' experience and the use of it for the hospitals, and maybe co-production. Maybe Catherine?
I don't know loads about it, and I can find out our plan, but I guess coming back to the consistency thing, we have a patient experience team, and they link together all the patient experience issues on behalf of the trust. Yeah. So when we have patient experience strategies, for example, we've got, and how and where and how we create that. So for example, part of the strategy is having patient governors on our board. As a trust, and so we try to make sure that the patient's view is held throughout all of the structures and how we organise it, how organise the trust in itself. So and it kind of, the central policies and procedures that we have filter through the trust, and so that's where you get some of the consistency, is that if one department's doing one thing, another's not, say, what's the right way, how do we go about it, write a policy, implement that policy, and then you get a bit more consistency and connection. So whether that's patient experience or overseas policies or international strategies or anything like that, it's run through the central team. And there's a team, a meeting called the Trust Management Executive that has representation from all the divisions, all the executive team, including governors and patients, where they make decisions about how things change and how things move forward.
Yes, thank you very much.
Can I just, so
yes.
That's the corporate side, actually down in the sort of in the trenches, actually on the front line of delivering the service. Because Oxford does a lot of research, we're very interested in patient-reported outcome measures. And actually, there's units, certainly within the surgical side, where we've got some experts in patient-reported outcome measures. So we build that into our research, and we also try and build in co-design of new services so that patients get to put their side of what they want. So that when we design and develop new services for the patients, then it's done in conjunction. And there's lots of examples of that. And we've got, maybe comes back to safety as well, we've got clinical improvement groups that we run on a monthly basis, where the clinicians will get together and work out what's going well, what's going badly. We have a quality improvement hub. So most physicians, surgeons will have quality improvement projects that they're running with juniors or with fellows to try and improve services. And actually at the center of that, I think there is a culture of putting what the patient wants at the center of design of services so that we actually deliver for the patients. And Mo mentioned culture. I think the culture in Oxford is very much a safety orientated culture, an improvement and innovative culture, but also we are repeatedly reminded and we try to put the patient at the center of that approach. And so the feedback that the patients give us is taken very seriously and we're very interested in it so that hopefully we can deliver what they want. And that might be outreach services, going out into the community. It might be changing clinic setups, the day case surgery. There's lots of examples where it's really being targeted by the patients to deliver what they want.
It's very good.
And in addition, I was just going to say, in addition to that, we do have liaison psychiatrists who support patients that we're looking after, and we have regular involvement of clinical psychologists for our cancer services and our hematology services and other areas where disease has been life-threatening or where it's ongoing chronic illness. And certainly where people have been discharged from ITU, from intensive care, there are support services available for them.
Thank you very much.
Can I just say one more thing? I think obviously hospitals can be like cheap hotels that charge you very expensive rates. But I think in Oxford, things can be slightly different. And I think even from a patient perspective, the catering, the menu that the patients are offered, it's quite diverse, where the hospital tries to offer, there are halal meals, for example, in Oxford.
Oh, thank you.
There is an imam for the patients if they require anything. So the hospital tries to cater for things that is not related to their medical needs as well. And I think that plays an important part when somebody is just there who's needing something that a pill can't sort out.
And along those lines, there's also a very good interpretation facility that we have access to, which we can access somebody immediately on the phone for almost every language.
Thank you. And can I ask one question? If you are so good, is there still any legitimation, any suits from the patient to Oxford Hospital? Yes, still?
There's always litigation. And we do have a legal team and an inquiries team, and we try and give very thorough investigation and answers where there has been an inquiry. Yeah.
Yes, thank you very much. Yes, we still have 30 minutes to talk. Maybe Dr. Eka Fiora, you have more questions? Or anybody on the floor? Nobody, a cardiologist, orthoped, hematologist, please come forward to ask question in Indonesian language.
Dr. Hani, maybe one more question.
Okay, Bu Eka. Bu Eka is a psychiatrist. She's an officer in the MOH, Indonesian MOH, but now she's in KARS.
Yeah.
Please.
Okay. Yeah, I want to know more about can you describe the step of Oxford University Hospital takes to instill a sense of accountability and dedication among its staff members toward maintaining service quality?
Difficult answer. difficult question. So, can you put one more diulang lagi pernyataannya, Bu.
Who was the question directed to? And are you able to repeat it? I'm really sorry.
Repeat, please.
I already read right in the chat room.
Is it the one about the valves, the heart valves?
Yes, can you?
Cynthia.
Is it in the chat room?
So the question is, can you describe the steps Oxford University Hospital takes to instill a sense of accountability and dedication among its staff members towards maintaining service quality? Maybe Catherine or Dr. Su would like to answer that.
So do you want to start?
I've got something if you guys want me to start, and maybe you can.
Okay. Go. You start, Mohammed.
So I think what Oxford does very well is there is no I, it's always a we. There's a collective sort of team working relationship. So, you know, Alex is a surgeon, but I know him on a personal level, and I know that he wouldn't say that this is my patient. So he would say that this is our patient, and what can we do for this patient in particular? And that just brings a team together. So you don't have to have one person carrying the burden to say that I am accountable for this person, because no one can deliver all aspects of health, of modern healthcare. And I, in particular, would say, as an intensivist, there are certain things that I would feel out of depth. And as I've highlighted, so if I have a bleeding patient, I would speak to a hematologist, because I am bound to encounter an abnormal coagulopathy. And that sort of collective working environment enables us to install that we are doing everything we can and we're dedicated towards the patient. And if anything happens to the patient, then we have done everything we can. Because I think we need to distinguish between adverse event versus complications, because these are two different things. And I think from a psychological perspective, the one thing that Oxford tries to do is bring in a collective team environment so that we can rule out various human factors. But from a medical perspective, we bring in the team with various know-hows that can deal with other things, and we get the support that we require with that. And unfortunately, unfavorable outcomes are bound to happen the more that you do sort of, or the higher your caseload happens. But it's also around collective decision-making that's also patient-centered. So if we have a complex patient, we don't say that we're going to do this without taking the patient's consent or what's in their best interest. So the patient is also involved, which means that the element of accountability is always there, but it's always shared, and it's always, I think it's always going back to the patient so that we can make sure that we're doing the best we can.
Interprofessional relationship is very good, yeah?
Yes.
Something, I mean, yes, the teamwork is absolutely crucial, and something that Oxford University Hospitals do that's quite easy to do is the way it values its staff. And there are very small things that make a real difference to the multidisciplinary team. For instance, there is a form template that you can just fill out as a thank you to somebody who has done something helpful, or just some praise for them. And it's such an easy thing, but it's actually so nice when you receive one. So that shouldn't be underestimated. There's also regular staff recognition awards that it's very easy to put forward a nomination. And they're small things to make people feel valued. And if people feel valued, then they are dedicated and they do want to work hard for the team.
And in terms of practicality, so it comes a bit back to the core values. So in terms of how that links into trying to instill that sense of accountability and consistency is, so we have values-based appraisals. So everyone gets appraised every year based on how they've met the values of the organisation.
Yes.
So there's always that link through from the strategy to how we function in practice. And if people aren't upholding the values, they get objectives in order to get them back on track and talk to them about why they can't and whatever. But the values based is both in the appraisals and now in interviews for non-medical staff probably. But the interviews also have they've got to display how they will meet the values of the organisation. And then there's a whole sort of gambit of central policies by which people's behaviour and attitudes have to kind of be aligned. You know, on an operational level with the staff, we've got to be really clear about their roles and responsibilities. So everyone has a job description, everyone has things that they are expected to achieve. They have objectives set to them every 3 months that have to be reviewed. And if people aren't, you know, on that track, what support do they need? How much do they need education? Do they need a little bit of extra help? And that keeps people aligned. It takes time and, you know, effort. And at the worst end of that, if people aren't and they aren't doing the right thing, there are policies in place to be consistent about how we approach that.
Yes, thank you.
Can I just add that? So I think we're kind of senior leaders in various departments, but actually the buy-in of both the junior doctors and the nurses are absolutely critical for delivering high quality care. And so in terms of, I think one of the questions was about accountability. We've got a very effective and widespread electronic patient records service. And so, for example, each month we will have an audit meeting and a teaching meeting with our junior doctors, and we will look at various parameters that can be measured, like how quickly results get signed off and looked at, or how people get DVT prophylaxis prescribed and at appropriate time points. And so we can audit ourselves, our department, on various things, and we can congratulate ourselves on things we do well, but also we can pinpoint when things are not going well to try and improve that. And I think the other thing as well is that there is definitely a no blame culture in the trust, which is really helpful in reporting things. And that if you report a problem, then it is. I mean, I've been through this system, and it's a truly non-blame culture. It's very much a culture to work out what the problem is and what everyone can do, rather than pointing the finger at an individual person saying it's all their fault, right, let's blame them. Which actually just instills this fantastic culture of improvement and responsibility that people take, knowing that they are being watched, but things will be investigated in an appropriate way, which is not a bullying culture. It's very much a nurturing culture that the consultants lead on, the management lead on, and that really promotes good accountability and buy-in from junior doctors and nurses to get involved in improvement structures within the trust. It's really helpful.
Yeah, thank you. Can we go to the next questions?
Yes,
Bisa tolong masukin Dr. Ramli Isakuku, tolong masukin. Terima kasih, Bu Eka.
Yeah, there is another question from Dr. Ramli to Dr. Muhammad Salim. May I have information according to your observation what animal valve is used by cardiac surgeon for replacement dysfunction valve patients?
Animal valve.
Can you repeat the question again?
May I have information according to your observation what animal valve which used by cardiac surgeon for replacement dysfunction valve patients?
Which type of valve?
Heart valve.
Yes, so it depends on the patient, their age, and what they consent to. So the usual two surgical valves that they use are either bovine valves or metallic valves.
for mitral stenosis or
So for either for mitral stenosis or for aortic.
which
So
one is more?
obviously we do more. So we do more mitral valve repair than we do mitral valve replacements. That's according to our own data. So we do more of a repair for the mitral valve. For the aortic valve, where replacement is the common practice, it depends on the age of the patient, which type of valve they get. So if we have a young patient, they will get a mechanical aortic valve. If we have a very young patient and they choose not to have a mechanical aortic valve, they get something called the Ross procedure. And this is a procedure where they take out the patient's native pulmonary valve, it gets implanted in the aortic valve position, and they get a bovine valve implanted in the pulmonary valve position. And this way they get longer longevity from the valve.
Bovine, yeah.
Yes.
Yes. Dr. Ramli, still any questions? He's a very senior doctor from
Okay.
from
Thank
Makassar.
you. Thank you, Dr. Muhammad Salim.
Okay.
It's enough there.
Yeah. Oh, very good.
Thank you.
Can I have one question, Catherine? Is the patient mostly out-of-pocket patients, or is it insurance patients usually?
So for the trust as a whole, most patients are under the government NHS scheme. We have about 5% of our patients are privately insured. It's quite a different demographic to yours. And of those, 70% are insured and 30% are self-paying out of pocket.
What about the foreign patient?
Mainly, there's different arrangements we've got, but primarily they're overseas. If they've come over to us and they've had an accident or an incident, then they're an overseas patient, which has got a different set of rules. But if people have come to us for specific treatment, for medical treatment, there is an insured there's kind of a private arrangement for those. So there's a chargeable arrangement for those.
Yeah, thank you
and
very
that's
much.
agreed prior to them coming. Can I just pick up one other issue that I wouldn't mind the team talking to you about? Because when I was there, there's an awful lot of people asking me about change and how you get consultants to change. Sometimes it's difficult because there was a lot of people there who knew what they wanted to do, had several conversations with different people, but they didn't know how to shift the goal to get there. Sometimes was consultants not changing or teams not wanting to change, and how they make that shift. So I talked a lot about identifying the people that are willing to listen and shift the bar, but I wouldn't mind our consultants just having their view on that, sitting from that perspective and seeing how potentially that can actually be enabled. So over to you guys.
Often the biggest barrier to change is lack of time. So people are familiar with the ways of doing things and don't have time to consider new ways. So I can give you an example of where I've instigated change. One of the most recent things very easily was let's take cancer patients. Many cancer patients are anemic, and they get a lot of blood transfusions. And I considered, well, actually, I don't think we're identifying iron deficiency in these patients. And as we know, blood transfusion suppresses red cell production. So it only gives symptomatic relief for just 72 hours at best. Whereas iron infusion fuels red cell production and would have a longer lasting effect. So trying to talk to consultant oncologists about that is very difficult because they're so busy and their main aims are trying to improve survival rates from the cancer itself, from making the diagnosis, from ensuring the cancer pathway is working well and patients get good quality care and experience. They're not going to be focused on so much on their anemia. So it's choosing the staff who will most benefit from the change. And they were the nurses on the day treatment unit. And so when I presented it to them, they absolutely ran with this idea because it meant that they weren't spending hours, one, trying to find a bed on the day treatment unit for a long transfusion with a prior group and save sample, so 2 appointments, and not being able to squeeze in the chemotherapy at the same time, to actually giving iron infusion over 15 minutes and then progressing with the chemotherapy on the day treatment unit. So the reduction in nursing time was enormous. And so, of course, they were able to assist me in presenting this and ensuring that this process worked. And the consultant oncologists were just happy to fall into place, but did not want to be bothered with reviewing the research, the data, and everything. That was really me and the nurses. So that's one example of just it's aligning with the benefits and who will benefit most from the change. Everyone wants the patient to benefit, but sometimes there is simply no time to be considering all these different issues.
Yeah, very, very, very good. Anybody want to give some addition? Yes.
So that's a really great question, and change management is a whole science of its own. And it's real. As I've been a consultant for 13 years, and in the first 2 or 3 years of being a consultant, I did what's called a leadership fellowship, which wasn't clinical, but was essentially to equip me about the science and knowledge of change management within the healthcare system. So I did a 18-month fellowship funded by the NHS with various projects, but learning about my own personality, learning about other people's personalities, learning how to think about change in a structured, scientific, organized way so that I could then work out who stakeholders were, I could make changes in a way that was much more likely to work. And these days, the Trust has run its own leadership programs so that consultants will go through and get experience of change. So the whole culture of the consultant body is there to understand change, the importance of change, and actually how to enact it. So that there is a gradual process of getting all of the consultants trained to understand that. And that moves the inertia of the hospital from being, I've always done it this way, to, is there a better way, which is really important. The other thing, the structure in the NHS is that there is not a head of a department generally, or if there is a head of a department, it's there purely as a management thing. But the clinical delivery of care is very much led by consultants, all of whom are in a level horizontal structure. So I am as important as the consultant who's just been appointed and the one who's about to retire, so that all of those consultants have an equal say in the table and they have the ability to change their own practice. So I do not have a leader in my department who says, you must always do it like that because I have done it like that. You cannot do anything else. In the NHS as a whole, but in Oxford particularly, it's very much a horizontal structure. So lots of new consultants may be appointed from other hospitals around the world and come in with new ideas, and actually they're allowed to implement those new ideas. So a lot of it is a personal understanding of change, a culture, and a sort of management structure within medicine that allows new things to flourish and develop. And I think they're really important. and the culture of putting time aside and understanding that this is important for the trust is also pretty critical. So some of it is me, some of it is everybody else, and some of it is the hospital structure.
Very good. It's new for us. Yeah. And
so I learned so much about myself and my colleagues to understand them that it just makes working out the barriers to change, working out how you can get around those barriers in a way to affect change is really important. And it's like one might learn how to treat chest pain, one can learn how to change.
Alex, do you still have old personnel or old professors who's not used to the computer? Yes, we have it still here.
We have a few around, but we have lots of younger consultants who can help them.
Yeah, yes, some nurses coming to help them. Okay, thank you very much. I think it's a very extended knowledge for us. Thank you very much. We are talking to one of the best hospital in the world. So maybe one day we are now dreaming, and maybe it will come true, and that we can stand in the same rank if we have a lot to share. Maybe Catherine, we can arrange something. Maybe one person talking about management, say about patient experience there, and one about clinician. So two speakers, they can talk 30 minutes and they can answer very slowly. And if it's possible, you can send the slides before. We can translate it in Indonesia, and the conversation will be very, very extended. Thank you very much for everybody. Thank you for Catherine, for Sue, for Muhammad Salim, for Alex, and for Cynthia. It's a very precious time for us. I see 230. It's no one leaving from their place. Everybody is listening till the end. So I give the closing speech to Dr. Jyoti, please. Tolong Dr. Jyoti. Pak Indra. Pak Indra, Dr. Jyoti masih ada?
Spotlight Dr. Jyoti.
Dr. Jyoti masih ada?
Matikan dulu ya sebentar.
Ya, siap. Ya, terima kasih Pak. Ada.
Oke. Masih ada.
Baik.
Tolong di pin ini ya. Ya, siap.
Bapak Ibu sekalian, kita sudah mendengarkan bagaimana ya beberapa pandangan-pandangan yang sangat positif. Bagaimana kita melihat cara pola pikir yang saya lihat itu adalah suatu pola pikir yang sangat positif ya di dalam cara berpikir secara global. Dan dengan demikian kepada para pembicara, to the speakers from Oxford University Hospital, we extend our sincere thanks once again to Ms. Catherine Kensington, Dr. Sue Effort,
Muhammad Salim,
also Dr. Muhammad Salim and Dr. Alex, also to Ms. Cynthia from Indonesian British Embassy in Jakarta, for your valuable presentation at tonight's KARS knowledge sharing event. Your sharing of knowledge is greatly for us appreciated and pivotal in the development of Indonesian hospitals toward international standard. We hope for the continuation of this fruitful cooperation in future occasion. Jadi kesempatan ini tentu kita akan berharap bahwa ke depan kita juga akan menghadirkan pembicara-pembicara internasional untuk menambah wawasan kita, terutama juga nanti pada acara Pitselnas yang akan datang. Sekali lagi terima kasih, dan dengan mengucap syukur alhamdulillah acara knowledge sharing KARS malam ini telah berhasil dilakukan dengan baik. Terima kasih pada semua pihak. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Pak Joti. Thank you Pak Joti. I will close with our last prayer, and maybe before anybody leaves, we will close it together so everybody can say hi after my prayer. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamdan na'imin, hamdan syakirin, hamdan yu'afi ni'amahu wa yukafi mazid. Ya Rabbana lakal hamdu wa lakal syukru kama yang badi di jalali wajhikal karimi wa asimi sultanik. Ya Allah, ya Rabbana, terima kasih atas segala karunia yang Kau berikan pada hari ini. Kami bisa berdiskusi dengan para ahli dari negara lain yang sudah sangat maju, ya Allah. Semoga mendorong kami untuk terus berani untuk berubah, berani untuk berjuang, untuk maju, untuk belajar berbicara, belajar berpikir, belajar menulis, untuk belajar berkomunikasi dengan dunia, walaupun dengan segala kemudahan IT yang sudah kami dapat pada saat ini. Ya Allah, terima kasih kepadamu. Berilah kami semua kesehatan, berikan semua pembicara barokahmu, karena untuk menyampaikan ilmu adalah suatu keutamaan di dalam Islam. Berikanlah kepada teman-teman se-Indonesia selalu rahmat dan berkah-Mu, ya Allah. Semoga kekeluargaan kami semakin erat, dan semoga KARS dapat terus membantu rumah sakit untuk maju. Wassalamualaikum warahmatullahi wabarakatuh. Thank you very much. Oke, silakan semua.